So I provided this AP view of both knee joint and of a fused skeleton, and I can see there is lateral displacement of the femur. There is multiple lytic and sclerotic lesions are noted in the epiphysis of bilateral femur as well as the proximal part of the tibia, and there is lateral displacement of bilateral femur joint, femur, and there is irregularity of the joint spaces, narrowing of joint spaces with irregularity of the periarticular region of both at the site of bone. Both sides of the bone are noted, and there is no any soft tissue swelling is noted. I cannot appreciate any periosteal reaction. The cortex is irregular, however, I cannot see any cortical break. There is subarticular cystic areas are also noted in it, and there is periarticular osteopenia is also noted. The diaphysis and the metaphysis of the bones are normal, and the visualized fibula is normal. There is no intra-articular any bony fragment I can appreciate, and so the adult patient with these my findings, I will consider these as a I cannot appreciate osteophytes as well. So my differential could be osteoarthritis and rheumatoid arthritis. Further, I will see the lateral views of this patient, and then a CT scan.
Okay, so you have given two differentials. Yes. So, Dr. Rubab, do you want me to explain each X-ray, or you have some particular methodology which I should follow? Is it fine that if I give tips and points at the end, or after every case?
Yes, after every case, I think you should be discussing.
Can I request someone else to describe the same X-ray?
Frontal radiograph of bilateral knee joints, in which I can see that there is only mildly reduced bone density, but it isn't specifically specified to periarticular areas. Then I can also see that there is mild subluxation along bilateral knee joint with geno-valgus deformity, and there is significantly reduced joint space along bilateral knee joint, both compartments, both medial and lateral. Then I can also see that there are significant periarticular sclerosis with the loss of epiphyseal height and wedge-shaped defects along the epiphysis on both sides, predominantly along the lateral compartment. Then I can see that there are no significant osteophytes. There is mild bilateral soft tissue swelling around the knee joint, but there is no definite lytic lesion or destruction. So in the rest of the bones, I do not see any other fracture, and I do not see any calcifications along the soft tissues or within the joint spaces, in the visualized joint spaces. So in these are the findings, and for the differentials, I would not be considering much of osteoarthritis because osteophytes are not seen here, but because there is bilateral involvement, yes, RA can be one possibility. Advanced osteoarthritis versus RA, this is what I would be thinking of.
Okay, so the X-ray is being described by two candidates, and thanks for the participation and good luck for the exam. I would advise you guys to revise the list of the musculoskeletal arthritis descriptors, and then differentials and final diagnosis. So if you see, because we all know that arthritis is described as bilateral, symmetrical, unilateral, and the type of joint involvement, density, and all those things, because it's a huge topic, so I cannot go into details, but I will just focus on this knee. So if as a candidate of FCPS or FRCR you appear in the exam, I would advise you that if both the joints are involved and you see erosions, so please always think about the erosive arthritis and or not the osteoarthritis. In advanced osteoarthritis, still you don't see these type of changes. Instead, you will see preserved bone density and huge osteophytes, and not the erosive arthritis with subluxations. So rheumatoid arthritis is a good thought, and the description needs to be further improved. That first you say what is the diagnosis, not that you say what is not the diagnosis. I mean, if you describe the X-ray, you will say that there are changes of erosive arthropathy at bilateral knee joints, nearly symmetrical with subluxations and huge and large erosive changes and soft tissue swelling. So erosive arthritis at bilateral knee joints. So yes, rheumatoid arthritis is a possibility. So you can ask the examiner for if X-ray hands or clinical history, and you will summarize like this. And not that first you say that it's not osteoarthritis and then you say that. I mean, if you've figured out that it's not osteoarthritis, then don't say it's not osteoarthritis. Instead, you say what it is. And then usually they don't show MRI.
There is a moderate amount of knee joint effusion, then I can see that there is again extensive erosive changes along the articular surfaces, more so along the lateral tibial plateau. Then I can see that there is significant loss of joint space, and then there are few subarticular geodes. I can also see that there is loss of epiphyseal cartilage, and then I can see that there is significant soft tissue swelling and edema within the subcutaneous soft tissue. So a lot of erosions and subarticular geodes, but no osteophyte formation and extensive erosive changes with joint effusion, as well as the subluxation which was seen on X-ray. So yeah, it is supporting again the diagnosis of erosive arthropathy.
So I am provided with the chest X-ray frontal projection of a female patient. I can appreciate that the right breast shadow, left breast shadow appears to be dense. Coming towards the lung fields, there is mild reduction in size of the left lung field, and there is homogeneous opacification of the left lower zone that is obscuring the left costophrenic angle as well as the cardiac silhouette, and it is extending around along the mediastinum. There is also nodularity, and pleural thickening is identified along the lateral aspect of the pleura and towards the apex. However, there is no significant subtle mediastinal shift, but no significant mediastinal shift is seen. So the right lung and costophrenic appeals are unremarkable. And coming towards the bones appear grossly unremarkable. So overall, summarizing my findings, this is most likely some mass lesion in the left lower zone with pleural thickening and pleural effusion as well. So, ma'am, do we have lateral view of this patient? Hello.
What do you want to see on lateral view? I have a CT scan of this patient, and what are your differentials on this X-ray?
Ma'am, there is significant pleural thickening as well. So, but this is a female patient. It can be a pleural disease as well. It can be tubercular involvement of the pleura, or it can be metastatic disease. It can be a mesothelioma, and it also has a pleural effusion. So I would definitely go for further evaluation and CT scan. So there is some mass hidden in the left lower zone also.
Yeah, very nice description and very nice differential diagnosis. I have a CT scan, so I will show you the CT images. First of all, I will scroll mediastinal windows and then lung windows. So you can always request me to for a second review if you think I was fast. So first you concentrate on the mediastinal window and then later on the lung window, right?
Okay, ma'am.
Because obviously RSP is also heading towards this type of exam, may not be in next 1 or 2 years, but definitely they will adopt the same method. So in exam, if anyone is appearing in FRCR and also for future FCPS exams, they will give you windows and at one time they will give you mediastinal windows. I'm just I've just split it into 2 so that other candidates, they can have a look on the lung window as well. But the candidate who is sitting on the hot seat, just review the mediastinal window and later on you can review the lung window.
Okay, ma'am. Okay, I am
describing this.
Yeah. Okay, these are the axial sections of CT scan chest with contrast, mediastinal and lung window. I can appreciate that there is a soft tissue, a fluid density mass, mass is identified in the left lung field, and it has enhancing walls, and it has internal nodular bubbly margins, and it has somewhat underlying lung collapse component in the lower zones as well, and it is surrounding the lateral wall, posterior, and as well as the majority of the mediastinal pleura. And there is also significant loss of the lung volume noted, and there is sir, can you just scroll through mediastinum? I just want to see the lymphadenopathy, if it's present or not. So yes, there is some lymph nodes also identified, and I cannot appreciate rib erosion on these this mediastinal window. So I would narrow down my differentials to it can be mesothelioma, or I would like to ask history of the patient, if he has any exposure to the she has TB contact, or it can be a tuberculous empyema, because it has enhancing walls and there is also a fluid collection within it. So these are my 2 differentials.
Okay, did you have you seen the lung windows?
No, ma'am.
Can you please review the lung window?
Yes, ma'am. I can appreciate fine subpleural nodules in the right lung as well. There are almost 2 to 3 mm in size. So this can be a metastatic. These can be metastatic deposits as well.
Yeah. Okay. Fine. So, what are the characteristic feature of mesothelioma on chest X-ray and CT scan?
Ma'am, it is basically solid lesion, and in cases of pleura, so that it is fixed. It has calcified plaques. It has nodular margins, inner nodular margins, and the involvement of the mediastinal pleura indicates malignancy, and
what is your top differential for this case?
Ma'am, it is mesothelioma, but I cannot still. I
So
would
mesothelioma or metastatic disease, right?
Yeah. Yes.
Or I mean, and obviously biopsy is needed, but tuberculosis will not be a differential, because tuberculosis, the hallmark features of tuberculosis, if you say acute, are the consolidations and then pleural effusions, and then if it is acute on chronic, then fibrosis. If you are thinking that there is collapse and that may be due to tuberculosis, but then you should have been able to see the tuberculous fibrosis with cicatrization, collapse, and bronchiectasis. So if these changes are not present on X-ray, and if these changes are not present on lung, and instead you are looking at a soft tissue mass which is pleural based, encasing entire lung with reduced lung volume, even very clearly reduced lung volume. So your first differential would be mesothelioma or metastasis. Yes, I agree. At times, lung cancer invading the pleura can be in the differential, but not the tuberculosis. And also, you will always give descriptors about the resectability of the mass, because that's what the surgeons and the pulmonologists would like to know, that if they do pneumonectomy on the left side or partial pneumonectomy, is that a chance? So that's what they would like to assess you during exam, and whether you have seen the right lung or not, because even if this area would have been smaller with mets on the right side, this would upstage to, the stage would go to sky high, so that a surgical option won't be there. Also, you will also share with the examiner that I don't see calcifications, but I can see that a soft tissue mass is extending posteriorly across the wall. They will show you, even in FCPS, they will show you the 1-2 targeted images on soft tissue window with such soft tissue masses. So they would expect you to pick this finding and this nodule as well. And they would expect you to find the mets which were present on the right side. So the rib, look at this, the shape of the rib. Even if I don't go to the bone windows, it was visible. So that's what. So it's just that when we sit on the hot seat, we are just a little nervous. So things they start. We are not able to concentrate. But the practice actually makes us perfect. So just keep practicing, so that whatever you know, you all can reproduce that, and you just don't underperform because of lack of practice, right? So now it's easy to practice, and then you will also share that there are risks of other cancer, GI cancer. So would like to, as you said, asbestos history, and also the esophagus, abdominal organs for other findings. For example,
ma'am, this is it necessary that calcified pleural plaques are present in?
Yes, there are some calcific specks, but not. And you see, one is here.
Yeah.
And so, I mean, it's not that you always see extensive calcification. With these calcific plaques, you can raise a possibility, right? Always ask for the bone windows, and always give description of the additional associations and complications of the known disease entity, right?
Okay, ma'am. Okay, thank you so much.
Okay, ma'am.
Young patient came with dizziness and drowsiness, sudden onset.
I have been provided with the CT axis scan brain window of a patient, non-contrast, plain CT, and I can appreciate there is a irregular, ill-defined hypodense area in the high parietal region, on the right side, and with the slight effacement of the ipsilateral sulci and gyri, and there is this hypodense area is extending up to the central sulcus, right central sulcus, and it is also causing. Ma'am, please can you scroll back again? And there is no midline shift or any other significant mass effect in the brain parenchyma, and and there is no surrounding any other pathology, and so my top most differential would be ischemic infarct.
Okay, so what is the differential diagnosis?
So, ma'am, topmost differential diagnosis would be an infarct.
Okay. And do you want to confirm it further? Do you want any other images?
Ma'am, I would like to go further on the MRI for the
Okay, so I will give you the selected MR images. And I will also share with you the sequences, because we also share the sequence name with the candidates during the examination. So this is T2 and this is FLAIR sequence, right? So first
okay,
we look at the T2, then FLAIR, and then describe.
These are the selected images of the CT brain, MRI brain axial window, showing T2 and a stir image, flare image, and I can appreciate that there is a well-defined, slightly lobulated, hyper intense signal area with the slightly peripherally marked in intense signals, and it's also hyper intense on the flare images, and it's not suppressed, and so it's the and it's there is no midline shift and there is ipsilateral effacement of sulci and gyri adjacent to the lesion, and the other brain parenchyma is unremarkable and is extending to the central sulcus, and also slightly not occipital region. Okay, ma'am, this my topmost differential would be.
Let me show you some selected images, right? So your description was nice, and it was not. It is fine, because when you look at the images, selected images, then you will be able to find what it is. So these are. Wait.
Ma'am,
so I will show you.
Young patient.
Yeah, a very young patient, and no history of hypertension or diabetes, and I will show you the post-contrast images. Please start looking from. So this is axial post-contrast MRI.
Okay, ma'am. Ma'am, both are post-contrast, ma'am.
This one is post-contrast. This again, the same flare image, right?
Okay,
I will show you the coronal post-contrast now. Please look at other structures as well, including the vessels and dural sinuses.
Ma'am, can I see the axial again contrast image, axial contrast?
Yes. This is internal jugular vein.
Yes, ma'am.
Okay.
Ma'am, I cannot appreciate the right internal jugular vein. It is either again, if I can see that particular view of the vessels, and there is
this is a
mild
difficult
surrounding
case.
peripheral enhancement. Yes, ma'am.
Yeah,
and
so this is a difficult case, and the reason I'm sharing with you is not that you give exact diagnosis. I want to teach you, all of you, some points here. So this is the CTV of the same patient.
Okay,
now keep looking, and then you describe, right? Let me change the window. Do you see any abnormality?
Ma'am,
let me go to the vertex.
Yes.
Okay. So do you see any abnormality?
Ma'am, please can you scroll once again from the vertex?
Do you see any abnormality on this image?
Ma'am, I can appreciate some filling defect in the straight sinus.
This is
superior sagittal sinus, and ma'am, this is empty delta sign, and it is extending up till the anteriorly, and I can appreciate that there is also filling defect extending up to the sigmoid sinus, and still extending up till the left jugular, left transverse sinus, and ma'am, there is also filling defect noted in the internal jugular, ma'am, it's vein or ma'am, jugular vein. Yes, ma'am. Internal jugular vein, and also there is ma'am, so this is the venous thrombosis and causing the infarct and hemorrhagic infarct.
Yeah, so the venous infarct can be hemorrhagic or non-hemorrhagic. The purpose was to show you guys that there was area of edema extending to the cortex. If you say this in ischemic infarct or infarct on CT, that's fine. But then you will look at the sinuses always, and in exam they will show you the dedicated images through that area, and you will always look at the dural sinuses. So the left one was, I'm not sure, maybe you cannot appreciate on this system, but the left one was definitely more dense and larger because of the clot, and superiorly the superior sagittal sinus was also dense. And then we did MRI. The MRI actually showed all the features, because normally you see signal void. So there was bright signal, and if I am reviewing this case on online, so it will be difficult. But the purpose of this case is they always show you dural sinus thrombosis. So whenever you see any infarct or vasogenic edema, it's not always that they will give you a typical case of bilateral venous infarcts. At times they can show you the unilateral infarct, and all. So you will always look for the dural sinuses, their hyperdensity on CT, and if you see definite high density with this kind of appearance, so always ask for MRI or MRV, and then the obviously most diagnostic is CTV. So and always try to look for the signal void on T2 weighted images. If it is absent, like in this case, you can see the transverse sinus is darker here, and it is showing a clot on T2 weighted images. And this was also present on FLAIR images. You can see here, and you can see this area. So this was not normal. So this was a case of dural sinus thrombosis and with infarct on the right side. It was not completely hemorrhagic infarct, only trace hemorrhage was present.
Ma'am, for
anyone has any
I would like to GRE image for this hemorrhagic.
Yeah, definitely. You can ask for GRE. I'm sorry, I don't have GRE at present.
Ma'am, did we always get the T2 and T1 labeled images? Ma'am, sequences
the examiner always help you. Yes, they always do. I've been in the exam for the past 3-4 years with 2 exams per year, and they always, I didn't see any case when they say, no, we will not tell you what is the sequence. I have never encountered any such scenario.
Okay, thank you so much, sir.